Hello everyone, my name is Ultinish. I'm an European board-certified nephrologist, and I'm currently working in an academic hospital in Oporto, Portugal. Uh, I was born in Madeira Island, which is an island in the Atlantic Ocean, mostly known for its beautiful landscapes, its New Year's Eve fireworks, but also for being the hometown of Cristiano Ronaldo, one of the best footballers of all time. My main interest in nephrology is diagnostic and interventional nephrology. Naturally, I am a point of care ultrasound enthusiast. Well, the work behind this paper was performed mostly during my 6 month internship in peritoneal dialysis, which is quite standard for Portuguese nephrology trainees. At the time, I had already been practicing point of care ultrasound for about a year, and I began researching about possible applications in PD. Well, interestingly, I learned that there were some old papers from 89 and 94 that already showed that the ultrasound examination of the catheter tract could be useful to diagnose unsuspected tunnel infection, to direct early therapy, to confirm or the resolution or the persistence of these infections. Despite this, the community never really gave much thought into this. Guidelines never really emphasized it, and ultrasound was rarely ordered for this kind of infections, both in my hospital and for what I could tell in other PD centers in Portugal. I mean, I kind of get it in clinical practice. Radiology performed ultrasound means the use of more resources, probably more patient visits, and it's a lot more time consuming. Sometimes it's even hard to have an access to a radiologist or even an ultrasound machine. So now our rationale was that since pocket and portable machines are more accessible nowadays, and point of care ultrasound is gaining traction in nephrology, maybe we could develop a study that could show that nephrologists can perform themselves the ultrasound of the PD catheter, and that would expand its use. So we designed a single center observational study that aimed to evaluate the accuracy of point of care ultrasound for the diagnosis of peritoneal dialysis catheter related infections. We enrolled 16 patients with a clinical suspicion of catheter related infection, as well as 9 controls. I have to say that all of our PD catheters are double cuffed and have a swan neck conformation and are placed under laparoscopy with the help of colleagues from general surgery. We defined the peritoneal dialysis catheter-related infection as a purulent discharge with or without inflammatory signs in the exit site or the subcutaneous tunnel, plus a positive microbiological culture collected from the exit site. The point of care ultrasound was performed by myself, where I used a Samsung machine with a standard linear probe. After applying a transparent adhesive film dressing at the exit site to ensure no contamination. We considered the POCUS positive when we found an anechoic collection in relation to the external cuff or the catheter tunnel. Uh, our physical examinations findings were coded by our nurses using the exit site scoring system. So we aimed to evaluate the diagnostic accuracy uh, of the point of care ultrasound. Since this was the aim, no clinical decisions were made by the PD specialists based on the ultrasound findings. Surprisingly, we found that all cases of peritoneal dialysis catheter-related infections had a positive point-of-care ultrasound, and in contrast, none of the controls had a positive point-of-care ultrasound, which is something that has been previously reported in the literature. Due to this, and surprisingly, our ROC of point-of-care ultrasound was very high, 0.91, for the diagnosis of catheter-related infection, while physical examination was only moderate, 0.6. Also, none of our controls had a positive POCUS evaluation, even when suspected cases had a negative POCUS, and they had a similar rate of infections as the control group at a 1 month follow-up. So this is quite reassuring for the clinician. If you suspect of an infection, you perform POCUS, you don't see any collection related to your external cuff, you can just follow up your patient without needing to start antibiotic therapy. Uh, we also found out that the size of the collection is maybe associated with adverse outcomes, such as relapse or peritonitis, and this is consistent with other findings in the literature. Although we believe that our colleagues will not perform invasive treatments such as cuff shaving or catheter removal without a trial of antibiotics, the point of care ultrasound, besides improving diagnosis, could hint the clinician which patients will probably fail conservative treatment. And reflecting on this, maybe we should be more proactive approach, like early cuff shaving, when we detect significant collections after a standard course of antibiotic treatment. Also, it has been shown by other groups that the persistence of the hypoanechoic area around the cuff or even the catheter more than 1 millimeter after 2 week course of antibiotic therapy or even involvement of the internal cuff is usually a sign of poor catheter prognosis and elevated risk of peritonitis. In this situation, the catheter removal is usually recommended. Well, our study has obvious limitations, such as its single-center nature and small number of patients enrolled. Also, we only considered cases with a positive microbiological culture from the exit site, and also we included some patients with previous recent catheter infection, which could overestimate the POCUS diagnostic effect. Also, point-of-care ultrasound information, although it was not used for clinical decision-making, our specialists were not blinded while I was conducting the point of care ultrasound examination, which could induce some unconscious bias. Well, but our study shows that nephrology performed POCUS is not only feasible but also superior to physical examination for the diagnosis of catheter-related infections in peritoneal dialysis patients when there is a clinical suspicion. To my knowledge, there haven't been any follow-up studies from other groups, but interestingly, there has been an increase in publications, both in traditional and in social media, about the role of ultrasound in peritoneal dialysis, not only for infection diagnosis, also follow-up and prognostic relevance, but also mechanical dysfunction cases, tip malpositioning, or even ultrasound-guided placement. There is actually a recent sorry, there is a recent very good review about this in by Granata and coworkers. They're Italian. It has been published in the Journal of Ultrasound in Medicine, and it's called the underrated role of ultrasound in peritoneal dialysis. It's quite a good educational review, so you might want to take a look at that. And to sum up, POCUS in peritoneal dialysis catheter-related infection is simple, quick, easy to perform, and it's safe to the patient and should be considered by nephrologists with access to an ultrasound machine. Thank you for watching, and I will see you in the Nephro World Cup.